start this lecture, we're going to talk about the BIRADS Lexicon. Going to describe to you all these descriptor terms, and we're going to really focus on telling you my experience of using these terms. As an update, I'll show you images that we've been performing on the 3 Tesla, and then finally we'll just show you lots of images so you get to see what these descriptor terms are about. So the overview is just a brief discussion of high-field imaging as it pertains to breast imaging. The bulk of the talk is going to focus on a morphologic and kinetic analysis in the evaluation of a lesion. Then we're going to just briefly discuss MR spectroscopy. So in the second lecture I'll give you, I actually will go over the protocol for the 1.5 Tesla. So the excitement about 3 Tesla is really because ideally you're going to be able to get double the signal to noise ratio. And for breast imaging, that really means that you're going to have, at the end of the day, increased spectral separation, which means you'll have improved fat suppression and also improved spectroscopy by able to look at smaller lesions and also with a faster acquisition time. So what are the challenges? Although in theory you should be able to get twice the signal to noise, in practice it's really not always realized, because as you're trying to optimize the image, you have to adjust various parameters, and especially if you're selecting a higher bandwidth, you end up overall with a smaller degree of improvement in signal to noise. Also, the higher field magnets, you have higher susceptibility effects. You have also markedly increased motion artifact as well. So what have I learned so far? Well, basically the optimized protocol for the 1.5 Tesla is not necessarily translatable to the 3 Tesla, and really that's because we've learned that the T1 and T2 relaxation of normal breast tissue changes from the 2 different field strengths. So at the end of the day, we really, like I said, have to alter multiple parameters in order to get maximal signal to noise, contrast to noise, and hopefully a decreased scan time at the 3 Tesla. So one of the things which you can do routinely at 3T, which helps, is parallel imaging. What this means is you can acquire images of both breasts simultaneously. And that means, obviously, decreased acquisition time. But what we're hoping is you will certainly get an increased spatial resolution with just a slight trade-off in the temporal resolution. So here's an example. This is a T2 image of the breast. This is axial, and one is done with iPad. That is the Siemens sequence for parallel imaging, and you're going to tell me, which image was performed with and without this iPad. To me, it looks the same. You can still see the area with bright and dark, and I really couldn't tell, but this image was performed with iPad at only 1.5 minutes, and this is the traditional sequence, which is almost double in time. Like I said, I think almost identical image quality. So our goals, 3T, really is to maximize the spatial resolution. I think that the MR lexicon is really going to help when you're looking at the morphologic analysis of a mass. And this really is our protocol. The Siemens 3T units called Trio, upgraded TIMS, and what we use is a standard 4-channel coil. Our protocol is to do bilateral breasts. We always obtain a sagittal acquisition. Gadolinium is given at a rate of 2 cc's per second. We will obtain the routine T2. As I mentioned, everything is parallel imaging. After that, you obtain the T1, and then we're going to obtain 4 dynamic scans through both breasts. So actually, this brings the whole imaging time down to about a little more than 10 minutes. So certainly a lot faster than what you can get on the 1.5 Tesla system. This is what the coils look like. This is the standard 4-channel coil where we perform all of our diagnostic studies on. This is the 7-channel coil, and with this coil, the benefit is that you can perform localizations and biopsies from both the medial and lateral approach. So now let's get back to the lexicon. At the end of the day, this is a whole series of descriptor terms which has been used to describe enhancement. So what exactly is enhancement? Well, you're going to be looking for tissue that's going to appear to be a little bit brighter than the normal glandular tissue. That's all we're looking for. And you want to look at this enhancement ideally on the first post-contrast scan. And then if you do see a lesion that appears bright, you're going to go ahead and review everything, the subtraction images as well as the pre and post-contrast images. So after you've seen something that enhances, it's going to be divided into 3 general categories. It's either going to be a focus, a mass-like lesion, or a non-mass-like lesion. So a focus are these little tiny dot-like areas of enhancement. They're going to be very small, less than 5 millimeters. A mass lesion is a true focal mass, and when you describe the shape and the margins, you're going to use descriptor terms, which is analogous to that for mammography and ultrasound. What is unique for MR is that you are going to be able to describe the internal enhancement pattern. The last category I think is the hardest. This is a non-mass-like area of enhancement. If it's a small area, you can think of it as being enhancement that's either going to be in a linear, ductal, or segmental distribution. If it's more extensive, you're going to think of it as being enhancement in a focal area, region, or multiple regions. So I'm going to show examples of all these. For the purpose of this talk, unless otherwise specified, all images have been obtained at the 3 Tesla, and all of these are post-SCAD subtraction images that you're looking at. So on your left, this is what we mean by a focus, just little tiny dot-like areas of enhancement in the background of normal tissue, and just that this appears a little bit more brighter than the adjacent normal tissue. Next, you have what's called a mass. Here you can see the mass has really well-defined borders, and it's easy for it to really stand out. And that's in contrast to this, where this is really a vague area of enhancement. This is going to definitely change in shape when you're going to analyze it through different planes. That's a non-mass-like area of enhancement. So let's just go ahead and briefly discuss focus. Focus is these tiny little ditzels that you're seeing in the breast. So it's these little round spots here and there in a background of some normal blood vessels. There usually are multiple little tiny dots you see, and you really need to be careful because in this example, you can see this dot actually looks a little bit irregular compared with the adjacent foci. So we thought that was abnormal, called the patient back for a dedicated mammogram, which was also normal, and then on ultrasound, we saw a very small, ill-defined hypoechoic mass. This was biopsied, and this is a 5 millimeter cancer. So in addition to showing you images, I've also have some schematic diagrams to show you so you can really appreciate the differences between mass and non-mass like enhancement. So this is a mass. You can see it, you can see its shape. It's going to hold up in all 3 planes. Linear and ductal is going to be a line. Ductal is really going towards the nipple, and sometimes it can be branching as well. So think of these as correlating to calcifications on a mammogram. And if you have multiple areas of ductal enhancement, it's going to be in a segmental distribution. So why is this lexicon important? Because it lets your referring doctors know what you're thinking about, whether you're going to be implying a benign or malignant lesion. So if you're thinking of a mass and you're describing it as round, oval, or lobulated with smooth borders, just like on mammography and ultrasound, you're thinking of benign entities. Unique to MR is being able to describe the enhancement pattern. So things such as non-enhancing internal septations or a homogeneous enhancing mass generally imply benign entities. Another general rule is if the mass doesn't enhance, it almost certainly is going to be benign. The only caution is if on a mammogram, what you're seeing is suspicious calcifications and the entity that you're thinking of is DCIS. Sometimes that will not enhance, and you really need to focus on the mammographic finding. Similarly, these features can be used to describe suspicious findings, like mammography and ultrasound. You can see an irregular mass or speculated margins. But again, unique is this pattern of enhancement. I think it's just another way for us to analyze the mass. It can either be rim, heterogeneous, central, or it can have enhancing septations, all descriptive terms of pattern of enhancement, which is suspicious. And unfortunately, there is going to be some overlap of these malignant features, and they will be seen in benign entities such as radioscar and fibrocystic changes. So we're going to first describe mass shape. These are actually images which was shown in a older ACR lexicon. So this is what I mean. A round mass, really smooth, looks like a circle. Contrast that to an oval mass and a gentle lobulation mass. So all these three shapes usually imply benign disease. That's in contrast to the ones on the bottom. These are all irregular masses, where this is just a little bit irregular, and this is somewhat a little bit more concerning. And the mass in your far right is certainly very concerning for malignancy. And this is what it looks like. So, and this is a round mass, a little bit of peripheral enhancement. It's represented a inflammatory cyst. Next, oval mass, pretty much homogeneous enhancing. This is what a classic fibroadenoma looks like. On these images, you can actually see two lobulate masses, and these are normal axillary lymph nodes. The image on your far right, this is actually probably similar to this, a very irregular mass. You can see the jagged, angular margins. Again, just think of it as an ultrasound finding where you would be suspicious, and this was a carcinoma. So once you describe the mass shape, what you're going to do next is actually describe the mass margins. It either is going to be smooth, irregular, or spiculated. Again, here are some examples. A mass, very smooth margins. You can almost outline the margins with a pen, and you can see no irregular borders. This is going to be another benign lymph node. Contrast this to this mass where the borders are a little bit indistinct, almost a little bit fuzzy, hard to tell from the normal background. This is an irregular margin. This was another cancer, and if it's really marked, this is what a classic cancer is going to look like. There's going to be speculations, associated architectural distortion. So this is a spectrum of from benign to worrisome mass margins. So what, again, is unique to MR is this slide. This is the mass internal enhancement. Homogeneous just implies that the mass is going to pick up contrast at the same rate. So it's going to appear completely white. Heterogeneous is where there's parts of the mass which is going to take up contrast more than others, but it's going to be in no particular distribution. Specific terms, it's going to be rim, where the periphery of the mass enhances more and highly suspicious for malignancy. The dark internal septations, overall the mass is homogeneously enhancing, but there are these little black lines which have enhanced less than the rest of the mass. This is sort of a classic appearance for a fibroadenoma. That's going to be in distinction to this mass. Homogeneous enhancing, however, in this case, these septations are going to appear a little bit more brighter than the rest of the breast tissue. Again, a rare sign, but really highly specific for malignancy. And similar to this, central enhancement. The center of the mass is going to appear brighter than the remainder of the enhancing mass itself. So again, let's go ahead and look at some images. So this mass, certainly homogeneous enhancing, appears really white, but in fact this is a cancer, and you can't suggest that because both of these have irregular borders, and in fact this is the primary lesion and these are satellite lesions. Contrast this to this case where this is what I mean by heterogeneous enhancement. Yes, overall it appears a little bit more brighter than a normal tissue, and some spots appear whiter, but really it's no distinctive pattern, and actually both of these are metastatic lymph nodes. And that's in contrast to this case. Here you can see the outline of the mass, and in the center it just appears brighter than a periphery, and I'll get more into this mass in my next lecture. The other three signs, first is going to be enhancing internal septations. Here, little white lines which appears brighter than the remaining tissue, spiculated borders, all findings classic for cancer. In this case, oval mass, you can see these little dark squiggly lines. That is what we mean when we're describing dark internal septations. If you see that, it really is classic for a benign fibroadenoma. And the last thing is this. This is a mass where it really is just the center which is not enhancing. So extensive clumpy peripheral rim enhancement in a large breast cancer. So at the end of the day, this is easy. If you realize something is a mass, you already know this because you do it with a mammography and ultrasound. You can analyze the shape and the margin. And the new thing you need to do is to describe the internal enhancement. As an overall generalization, these entities on top are going to imply benign disease, and these down here are going to imply a malignant process. And in fact, we have found that if you are using these lexicon terms, it really has a high negative predictive value for both benign and malignant lesions. So if something has smooth borders or lobulated borders, we already know it's going to be benign, but if you see this enhancement pattern, it's going to make you almost certain it is going to be a benign lesion. Similarly, if you're looking at malignant lesions, we know that spiculated and irregular borders are going to be highly suspicious for malignancy. However, this is new added information, the rim enhancement or ductal enhancement. If you see that, you can tell your referring clinicians, gosh, I'm really worried about this mass that I'm seeing on MR. So this is just image to show a few points. First is if you're looking just at the mass shape and margin, it doesn't matter what sequence you're looking at, T1, T2, post or subtraction. End of the day, you're trying to see, can I see the spicules? Is the margins easy to identify? What can I really make out about the shape of it? So you're going to try to see, in fact, if this holds up in all three planes, in the sagittal, axial, and coronal planes. This is just to show you in general, I prefer to do T2 imaging on a 3T. STIR, I think of a little bit more of a general body sequence, and I find that you have improved image contrast with a T2. Another benefit is that even if we are using a higher resolution with a 512 matrix, because you're using T2 imaging, you actually have a shorter acquisition time. So now let's see what we've learned. Here you go. This is a mass, a little bit irregular. I'm sorry, I gave away the answer. Here you go. You can see the margins. So first thing you do is describe the shape. It's going to be irregular. Then you can look at the margins on both planes. The shape is also irregular. Then you're going to look at the pattern of enhancement. This here certainly appears very bright. Back here it doesn't. So we're going to describe this internal enhancement pattern as heterogeneous. And in fact, this represents an invasive lobular carcinoma. Now, we're going to shift gears and describe, I think, the toughest category, which is these non-mass-like distributor. This is going to be described as a focal area, just one spot, regional, where it's more extensive, and multiple regions where you can see it really in different quadrants of the breast. The focal area, I try to think of it as being equivalent to asymmetric breast tissue that you're going to see on a mammogram. So, in fact, this is it, a focal enhancement. And just like the asymmetric breast tissue, you're going to see that it sort of changes in shape on the three different planes which you are acquiring the images on. And what is regional? Regional is going to be, well, these are areas which appear brighter in one spot. This is in normal fibrocystic changes. Contrast to this case where there's multiple regions which is enhancing. This is actually normal findings in a woman who's lactating. In contrast to this case, multiple areas of enhancement, and this is a case of diffuse adenocarcinoma. So I think the reason why the non-mass-like category is confusing is because right there we were describing essentially patchy tissue, and here now we're describing descriptive terms used for calcifications. So this is what we mean by linear. You can definitely see that it's in a straight line. However, these straight lines are not going to the nipple. Contrast this to ductal, where the calcifications, you can see in a straight line going to nipple, and if it's more extensive, you can see that it's branching. Segmental, as we've mentioned earlier, is just multiple ductal distribution. So in addition, you're also going to describe the internal enhancement for these non-mass. And if it's in these really small area, it's hard to tell. But again, the terms are similar. First, it's going to be homogeneous. This woman has predominantly fatty breasts, and you can see in this normal cholangial tissue, areas really appear sort of homogeneously white, and this is just normal fibrocystic enhancement. This is the more classic pattern for fibrocystic. Tiny little dot-like areas of enhancement. This is called stipple. In fact, this is what we're seeing here. Once you see that, really it is pretty specific for being normal fibrocystic changes. Category that's hard is heterogeneous. And again, I'm just going to think of it as the fact that one area appears brighter than the rest, no distinctive pattern. And that's in contrast to this, which is going to be clumped enhancement. Clumped means that you have these linear areas of enhancement, but it looks very lumpy, bumpy, just looks as though it can't be smooth, and that is really classic for DCIS. And again, if you're looking at these malignant features, we know ductal and segmental distribution, very suspicious, but if you can add the clumped or heterogeneous enhancement, you really have increased your level of suspicion significantly. Unfortunately, there's lots of overlap with fibrocystic changes. I think the correlate is with some indeterminate calcification in the mammogram. You think it's probably fibrocystic changes, but you can't exclude DCIS and you're forced to biopsy those calcifications. Like I said, clumped is very hard to analyze, especially when it's involved in a small area. So here, this is what I mean by sort of a branching pattern. Another way I think of clumped is when I'm analyzing calcifications. These little tiny dots of enhancement, one does not really look like the other, and sometimes you can think as clumped as maybe being analogous to pleomorphic. When the enhancement is a little bit more marked, here you can see this clumped or cobblestone appearance just looks very lumpy, bumpy, certainly doesn't look like the normal fibrocystic enhancement seen more superiorly. When it's extensive like this, I think it's much easier to tell. Here's the patient's known cancer, extensive adenopathy, and all of this is extensive segmental clumped enhancement. So when it's this extensive, of course, it's a no-brainer. You're going to say this is definitely suspicious for DCIS. So in really imaging patients in 1.5 and 3T and talking to surgeons, we've really decided that the way to increase the specificity of MR is by improving a higher spatial resolution. In fact, Christian Kuhl just published this data where she had imaged 30 patients using a standard protocol with 256 matrix and another high res of 512. Because you're doing high resolution, it's going to take a longer time. And in fact, it takes about almost twice as long to obtain these high resolution images. However, when they performed their readout session, they noticed that this increase in spatial resolution had increased their diagnostic confidence. There was a little bit of loss of information trying to look at the enhancement rate, but the overall time intensity curves that were generated were unchanged between the two standard and high resolution protocols. So again, here's another example, just kind of demonstrating that effect. This patient is what we'll call region, a big blob area that appears bright. And I think on the 512 matrix, you can really appreciate that these in fact are thickened trabeculaurs, and I think it's a little bit harder to make that distinction when you're using a lower matrix. And again, if you have segmental clump enhancement, known cancer, but I think here you can really appreciate these ductal areas of enhancement. Clumpy, one really does not look like the other, and all of these are our high-res images being performed on a 3T. So is this lexicon perfect? No, it certainly has lots of problems. For us, we just did a consensus readout, and there was a lot of discrepancy. Is something an irregular mass? So I'm thinking of an invasive carcinoma, or something just a focal area of non-mass-like enhancement to suggest benign tissue. It really is hard to tell, and I will probably flip-flop when I'm reading out a series of films. And also these patterns of enhancement, when it's involved in such a small area, sometimes it really is hard to distinguish between stipple, clumped, or heterogeneous. So what we have all done is really try, like I said, to improve the spatial resolution. So what have we learned from imaging at a 3T? Well, fat suppression is easier because there's broader separation between fat and water. In general, you can maximize the contrast to noise. That's because gadolinium is going to stay constant. However, the T1 relaxivity of tissue becomes longer. And what the heck does that mean? At the end of the day, it means that the 3T hopefully will be able to distinguish differences between enhancing and not enhancing tissue a little bit more clearly. Here's an example. Patient has an area of architectural distortion on mammogram, and you're going to tell me which is the 1.5 and which is the 3T image. I think in both you can appreciate some spicules, but in fact, this is the 1.5 and this is the 3T. I think knowing that you can see a few more spicules, but at the end of the day, has that really changed your differential diagnosis? So an area that I haven't discussed yet is really the temporal resolution. So after you analyze the morphology, you're going to go ahead and give these time intensity curves. Type 1 is going to be benign, proliferative, constant, steady level of uptake of contrast in normal fibrocystic tissue. Contrast that to type 3, which is a rapid wash in and wash out. Type 2, you get in contrast, but it levels off and stays constant. So this is considered indeterminate. My own personal experience, these time intensity curves don't really help me that much. 85% of my curves are type 2. So at the end of the day, I'm really relying on the morphologic analysis. But here's an example where it actually worked. This is a patient with known cancer. When we plot these curves, we actually will place an ROI over the index lesion, ROI over an area of adjacent tissue, then a normal fat and a background. And what you can see in the cancer, not only do you have a rapid uptake, but the amount of GAD which is absorbed is much higher than normal tissue, and you'll be able to see that steep down sugar washout right away, not delayed out to about 6 or 8 minutes. You'll see this drop off quickly. Like I said, this is another case which is our routine case. Known cancer, multiple satellite lesions. Morphologically, I'm already very suspicious for cancer, but in fact, all I'm getting is this type 2 curve. So, in fact, this is a study which had triggered all of these time intensity curve. Christian Kuhl published a study saying that the time intensity curves had a high sensitivity and specificity. Really, very few of us have been able to reproduce those results. So actually, at the 3T, now we think of another way. I described to you those mass internal enhancement. We're trying to see if maybe we can scan the whole breast at high temporal rate and just look at the same slice over and over again and try to see if you can make a visual gestalt analysis of the pattern of enhancement. And if you can do that, maybe we'll get a little bit more temporal resolution. And like I said, with the parallel imaging, these higher temporal resolution becomes possible. So to summarize our experience of imaging the MR3T, the best quality images is if you're using its high resolution. Therefore, we perform a unilateral examination, meaning we acquire in the sagittal plane. As Dr. Rafferty mentioned earlier, we actually are acquiring isotropic, so the voxel is about 1 millimeter by 1 millimeter by 1 millimeter. Therefore, you can do multiplanar reconstruction in any plane, and I think that's especially helpful for the stipple and clumped pattern of enhancement. In addition, as I mentioned, we are trying to figure out various ways of manipulating the possible temporal information you can get at scanning at a high field magnet. But to date, the only thing that I can say is that these enhancement kinetic curves that we're obtaining at the 3T is comparable to that at the 1.5T. And as I showed you from the other slide earlier, it really remains to be seen that even though you're seeing additional information and detail, at the end of the day, is it really going to change the patient's management? I'm not sure about that at this point. So as you mentioned earlier, once you see a lesion, you're going to go ahead and give it a final lexicon. Just a general rule, if I read a study out as normal, I do not recommend a follow-up study in 1 year. I only do that in the high-risk screening population. BIRADS 3, probably benign finding, very controversial, we'll get to. BIRADS 4 or 5, you're recommending a biopsy. And category 6, the known cancer, you're performing the MR for an extent of disease evaluation. So again, what have we learned from these BIRADS lexicon? If a BIRADS 0, this is where you need the prior studies, the prior mammogram, ultrasound, and MR. When I first started, I was a stickler. I wouldn't read the studies unless I had those old studies. Truthfully, sometimes we never get them. So now I read these studies out as they come across. And then if there is a finding, I will then give it a BIRADS 0 and say that I do need the prior studies to give a definitive read. BIRADS 3, this is short of a follow-up. No one has really established what is the appropriate protocol. We've adopted a protocol that we use in mammography and ultrasound. So we have patients come back every 6 months for a total of 2 years. And then if that finding is unchanged, we consider it to be benign. However, the patient compliance is poor. Our internal audit shows that only 17% of patients placed in this category actually completed this follow-up protocol. And I think a big issue is that there's problems of reimbursement by insurance. Insurance isn't going to pay for it, the patients are not going to come back. Another point is if you're reading the MR and you're given a BIRADS 4, in your report you're saying that you're going to recommend target ultrasound and dedicated mammography. That's a 4. That's not a BIRADS 0 classification. Because if you see a finding with either ultrasound and mammography, you're going to pursue a biopsy. In the last minute, I'm just going to go ahead and discuss spectroscopy. Spectroscopy is a way of looking at the phospholipid metabolism in cell membranes. And the whole idea is that now maybe we can try to analyze metabolites throughout the body. In the breast, it's easy. It's just looking at the choline levels. And the initial study shows that you can see higher choline in malignant tissue and either no choline in normal tissue. So we're hoping that this additional information can help increase the specificity of MR. We routinely add it to our protocol on the 3T, but really in order for it to be universally used, the spectroscopy must be more automated, and you need to have a rapid acquisition time and post-processing. So what does the preliminary data show? It's very promising. This comes out from Michael Garwood's group at the Mayo Clinic, and they imaged 55 patients at 4 Tesla, and afterwards they did a retrospective read. One is conventional, just looking at morphologic and kinetic assessment, and the other was with morphologic, kinetic, and the choline information. And they concluded that with the additional information of spectroscopy, there is an increase in sensitivity, specificity, and inter-observer agreement. So these are just a couple examples. This is what we do. You can do spectroscopy at 1.5 or 3T. Once you identify the lesion, you place a voxel on the sagittal, axial, and coronal plane. We perform a single voxel spectroscopy, and these curves come up automatically for you. You try to see if there's a choline peak at 3.2 parts per million. Once you do that, you perform a post-processing. Now the choline is seen as a full-scale display, and in fact is correlated with a malignancy. Similarly, 3T case, again, you apply the voxel, run the sequence, and again, after you analyze the data, you can see that you obtain this peak. The hard part is shimming. Shimming is trying to get a narrow peak, and you can be sure that this isn't an artifactual peak. So what have we learned so far? This is just a normal volunteer imaging at 1.5 and 3T, and really it shows us that at the end of the day, you do get a nice choline peak at the 1.5, but at the 3T, you can cut down your voxel size in half, cut down your imaging time in half, and you still get the same peak. And in fact, if you even decrease the number of acquisitions, time is almost 1/3, and you really will get identical results. So it really remains to be seen whether spectroscopy will help us in analyzing these lesions. So I hope this general overview has helped you, and I thank you for your attention.